All right, good evening, everyone, and welcome to another great Canadian debate. I'm David Watson. I'm with the Macdonald-Laurier Institute, the #1 federal public policy think tank in Ottawa, and we're delighted to be hosting the two great debaters you'll be hearing from this evening. I'd like to thank you all for joining us, particularly on an evening when the Ottawa Senators are poised to go up 3-0 against the New York Rangers in the Stanley Cup playoffs. We'll endeavor to get you home for the third period. I'd also like to acknowledge the folks at home who are watching on the live stream on CPAC's website, and CPAC is going to be rebroadcasting the debate on the weekend. Tonight's debate topic is not a new one. In fact, complaining about or defending our single-payer healthcare system is almost as much a national pastime as that other game that you're missing as we speak. But we have a rare opportunity here to hear directly from two veterans of the front lines of the health policy battle. Indeed, the debate over Medicare is as urgent as ever today, in part thanks to one of our debaters. As I'm sure you're aware, Dr. Brian Day has made headlines over several years now as a case involving his BC clinic has wound its way through the courts and is now being heard by the Supreme Court of British Columbia. The other debater, Ujjal Dosanjh, has served as premier of that province and was later health minister in a federal government that invested tens of billions of dollars into the healthcare system. Between them will be Peter Milliken, our fine moderator, who is Canada's longest-serving Speaker of the House of Commons. Now I'd like to turn things over to Peter to properly introduce our debaters, get things started.
Thank you very much, David, and welcome, ladies and gentlemen. It's a pleasure to have another of these debates. I am delighted to have with us our two debaters this evening, and I thought I'd start with first outlining the format of the debate, then say a few words about them, and then I'll be asking for your views on the question that we're debating this evening. The debate consists first of a speaker for each side, given a total of 15 minutes now maximum for their opening remarks. Following those two 15-minute speeches, each will have 5 minutes to address a rebuttal of what the other said. And then we will open the floor to questions. And you will be able to ask questions of our debaters. There will be 3 questions asked in a row. Each question is maximum 1 minute. And tonight, for a slightly different thing, we're going to have our volunteers with microphones walking around. We'll pass the microphone to the person who's recognized to ask a question. So you won't have to come down the steps and line up or crowd out of your row to get to a microphone. It'll be passed to you if you've been recognized to ask a question. So it's 1 minute max per question. There'll be 3 questions, and then each of the debaters will be given 3 minutes to respond to the 3 questions that have been asked. And then we'll do 3 more questions, and then there'll be responses, and then there'll be 3 more questions max. And then we'll move on to the final discussion between the debaters, which will be 5-minute concluding remarks that each will then give. Before we begin the debate, there will be a motion. The motion will be put, the motion that they're debating will be put, and you'll be asked to express your views on it, whether you're in favor or opposed to it. And then we'll have the same question put after the conclusion of the remarks in the debate. Perhaps I can introduce our debaters tonight. Dr. Brian Day was born and raised in post-war Liverpool, England, and graduated in medicine from the University of Manchester in 1970. He has been a pioneer in arthroscopic surgery, and in 2004, he served as president of the Arthroscopy Association, sorry, I mispronounced that, of North America. He's the only orthopedic surgeon in the 150-year history of the Canadian Medical Association to have served as president. Dr. Day is founder and president of Cambie Surgeries Corporation, which over 20 years ago opened the first private hospital of its type in Canada. In 2009, together with 6 patient plaintiffs, 2 of whom have died while awaiting the trial date, can be mounted a constitutional challenge against prohibitions on patients' access to care. Ujjal Dosanjh was born into a politically active family in a small village in northern India. Both his father and maternal grandfather were involved in the country's movement for independence from Britain, and in Canada, as a lawyer, he was an outspoken advocate against religious extremism following the Air India bombing in 1985. Mr. Dosanjh is one of Canada's most successful politicians, serving as Premier of British Columbia and, more recently, as a Member of Parliament and Health Minister in the Martin government, where he worked to prevent the provinces from privatizing the public health care system. So, those are our two debaters, and the debate is on this, if I can call it a motion. Our broken health care system is infringing the rights of Canadians. Could all those who agree, please, or agree with the words of the motion, please raise your hand. Would those opposed please raise your hand? Okay, I think there's more agree than oppose. And who are undecided? A reasonable number there too. So we'll have an interesting discussion. Great. Well, it's my pleasure now to call upon Dr. Day to deliver his opening statement, 15 minutes, and I hope you enjoy the rest of the evening.
Thanks, Peter. So for Canadians who aren't patients and don't need timely access to health care, our system works pretty well. But for those who need health care, it's underperforming. And this debate will be broadcast on CPAC, and as many are aware, we're currently adjourned in a lawsuit in which our clinic and 6 patients are challenging Canadian laws that force Canadians to wait, suffer, and even die on wait lists. We tried to have the trial televised so that the owners of the health system, that is, you, the citizens of Canada, could observe and see firsthand government's arguments. Government lawyers fought our request, so we sought public scrutiny and transparency, but the government's rejected it. So I'd like to briefly describe the system that Ujjal is fighting to keep. I mean, we all believe that Canada is a great country. Macdonald-Laurier would be proud to see it ranked first among the world's countries in categories such as most reputable and admired by the Reputation Institute, best for business and G7 growth by Forbes, and best debt to GDP ratio by the OECD. But they'd turn over in their graves if they saw the level to which our health system is now ranked internationally. The World Health Organization ranked us 30th in the world. The European Health Consumer Index out of Sweden and Belgium compared us to 29 European countries with universal care, and they ranked us 23rd overall and last in value for money. Mark Britnell, in his book, In Search of the Perfect Health System, cited specific examples of excellence in 12 categories in 12 different countries that could form the basis of the best health system in the world. Not a single feature of Canada's health system figured in the list. Among highly developed nations, the Legatum Prosperity Index on Health ranked Canada 16th, and the Commonwealth Fund ranked us 10th of 11 countries, only the United States being worse. The Canadian Institute for Health Information, CIHI, notes that we are last in timely emergency room access, waits for GPs, waits for elective surgery, waits for specialists, access to drugs, access to dental care, and we also rate last in many technologies. Now, Air Korea is a North American airline, rated the worst airline performing carrier. It sets prices, dictates spending, owns and controls the facilities. It trains, employs, regulates, and funds the workers. It governs how, when, and where clients are served, determines the volume and quality of services. It self-regulates, self-evaluates, and outlaws competition. These are the principles that are used to operate our Canadian health system. We saw one BC example of the Corio approach in Canadian healthcare in the 1990s when Ujjal's NDP government was in power and demands for care were rising. Government's solution to increased demand was to severely cut back nursing school and medical school intake. And now governments complain that there aren't enough doctors and nurses. Contrast Canada's low-ranking health system with our highly rated education system. Many rate education as the most important service that a government can provide. How do supporters of choice in education reconcile their belief in a state monopoly of physician and hospital services? In education, parents who send their children to independent schools continue to pay taxes and support public education. They add resources. If our Medicare model were applied to education, private schools would be banned, and there would be a 1 to 2 year wait to get into school. Those waiting would be breaking the law if they or their parents tried to fund their education personally. The essential question in the BC constitutional trial has already been answered by the Supreme Court of Canada for Canadians living in Quebec. Do we live in a free and democratic society, and are we entitled to experience the freedoms that come with that privilege? Who owns our bodies? Is it us, or is it the government? Is it acceptable for governments to promise care, fail to deliver it, and simultaneously make it illegal to care for oneself? In BC, when the government contracts out to private clinics, they are making the decision that you can access that care privately. In every country on earth, communist regimes of China, North Korea, Cuba, Vietnam, and Laos included, a citizen has the right to look after their health when the government fails to do so. The strategy of government lawyers in the BC trial is to put forth protracted arguments and objections aimed at blocking the admission of evidence. Government has even argued that their own published reports and publications should not be allowed into evidence, and told the court that the BC Health Minister, who was called as a witness by us after admitting that hybrid systems in Europe, Australia, and New Zealand outperform us, had no information that would be relevant to the case. BC lists 85,000, which is a gross underestimate, of patients waiting for hospital admission. Procedures that were scheduled and performed in days in the early 1980s are now assigned a 6-month benchmark, developed in the era of Paul Martin and Ujjal. This prioritization is simply rationing. Across the country, thousands exceed those excessively long benchmarks. In BC, less than a half of those needing knee replacements receive them within the 6 months benchmark that deceptively excludes waits for consultations and investigations. Government targets are many times longer than patients or doctors want. Our health minister in BC is a veterinarian. He would lose his license to practice if he allowed a dog to wait in pain for even a week. Yet humans wait for years. Government lawyers argue, and they really do, that patients neither deteriorate nor suffer while waiting. In 1994, as our centre was being developed, the NDP government of the day boasted that they were contracting out surgeries to a private hospital in Washington state. Associate Deputy Minister Thea Vakil rejected the concept of allowing private MRI clinics in BC when I pointed out that 2/3 of the patients at the Bellingham MRI clinic were from BC. Her response to those traveling to the US was, if I could stop them at the border, I would. Again, in 1994, during Ujjal's time in provincial politics, a private corporation, InterHealth Canada, was formed. His government was joined by trade unions and others, including the Ontario NDP government of the day, as investors. The company's mandate was to develop private for-profit hospitals in other countries. Their efforts in the Middle East, China, and other countries were in developing such facilities, also in England. Their CEO was a former NDP cabinet minister from Saskatchewan. InterHealth recruited nurses and doctors to leave Canada and practice abroad. I was even targeted. And I know many of my opponents probably wish I'd gone. I continually receive letters from frustrated patients. One recent letter ended in this way. I am 84 years old. I am limping in pain. I can only walk a block. I need surgery, but I'm afraid I will be breaking the law if I come and get surgery sooner than is allowed in the public system. What shall I do? Another email. My 3-year-old has mild cerebral palsy and has been waiting 4 months for a surgical release on her foot. Can you please help her? The foot is stiffening in the deformed position. Opponents of today's motion might say, too bad, we need to support our public system, and you just have to wait or leave the country. An Italian law expert recently published a 14-page article in Italian in a journal in Italy. He wrote, I'm very fond of Canada, one of the best countries in the world, but Canada's system is tailor-made just for the very rich who can afford to get care abroad. Like most Canadians, I support a strong public health system. Assigning it a monopoly status and protecting it from competition and accountability is not the way to make it strong. When I started practice in the late 70s, if patients needed treatment, they received it promptly. Patients didn't languish in hospital corridors. As new technologies, drugs, and procedures have been developed, costs have risen. An aging population with chronic diseases have increased costs even more. The Canada Health Act of 1984 reduced choice and accountability. 4 of its 5 principles, universality, comprehensiveness, accessibility, portability, are ignored. The 5th, public administration, is the only one now enforced. Our system is not single payer. It's not universal, and it's not comprehensive. 70% of privileged Canadians have 2-tier private health insurance for things like eye care and psychological care. Recently, in BC, a 2-year-old died tragically. The grieving parents received an ambulance bill from the government with the explanation BC ambulance fees are not an insured benefit and ambulances are not medically necessary. Federal employees, RCMP, workers' compensation, Canadian Armed Forces, and federal prisoners are entitled to access private insurance and care. Canadians who are not in jail should have the same rights as those who are. Here in Ottawa, there was a closed hospital called the NDMC, where politicians and federal employees jumped the queue. I've treated well-known politicians and their families privately, so has another doctor in this audience. Even treating politicians who are architects of the Canada Health Act. We have documented ankle replacement surgery being contracted out to a private US hospital for $35,000 US by the Ontario government when our centre in Vancouver had quoted 15,000 Canadian for the same operation. But we were told Ontario could not support private Canadian medicine. A defendant in our case was BC Attorney General Barry Penner. He paid for spine surgery at a private BC clinic. The BC Health Minister excused him because government has never defined the term medically necessary. They continue to fight us in court. International experience with successful universal systems proves that competition improves performance. Stats Canada and CIHI data show that in Canada, the lowest socioeconomic groups have the worst outcomes and the worst access. It's not doing what Tommy Douglas said it would or should. Celebrities and famous athletes are treated at our centre. During the Vancouver Olympics, a Russian Olympic medalist and an American gold medal skier were legally able to access treatment at our clinic, while BC athletes were managed in defiance of current laws. Foreigners enjoy rights and freedoms here that Canadians don't. Does anyone really believe that a near $1 million a month hockey player should wait 18 months for a shoulder or knee operation that costs $5,000 to $10,000? The rich and powerful never wait. Many Canadian politicians, including people like Danny Williams, Belinda Stronach, Ed Lawson, Jean Chrétien, Paul Martin, Jack Layton, Joe Clark, Robert Baressa, and many others, these are all in the public domain, have accessed private care. It's naive to think that influential people wait like ordinary Canadians. Sir William Beveridge, founder of the British NHS, stated, "The state, in organizing security, should not stifle incentive, opportunity, responsibility. In establishing a national minimum, it should leave room and encouragement for voluntary action by each individual to provide more than that minimum for himself and his family." This is a philosophy embraced by every other developed nation. 2 of the 6 patient plaintiffs in our case died of cancer during the 8-year wait for trial. 3 of the remaining 4 are children. 2/3 of Canadian children wait a medically unacceptable period of time. A 16-year-old plaintiff in our case is paralyzed after waiting for life after waiting 27 months to get into BC Children's Hospital. 26% of doctors have had patients die on a wait list. There are gene mutations that indicate a high risk for developing breast cancer. In BC, 5 women a year develop cancer while on the list for surgery. This is Mental Health Week in Canada. 4,000 Canadians commit suicide each year. According to psychiatrists, half of them would survive if they had access to mental health. In 2005, the Supreme Court of Canada stated access to a waiting list is not access to care. The evidence shows that delays in the public system are widespread and patients die as a result of waiting lists. Thank you.
Thank you. Thank you. I now call on the Honourable Ujjal Dosanjh to address us for his 15-minute intervention.
Thank you. Perhaps Dr. Day should take up politics. He wouldn't be so grumpy about politicians. Because if politicians are the problem, then that perhaps is the course that he should take. Motion as crafted, I believe, has several flaws. Firstly, it assumes the existence of legal rights to health care as Canadians. Dr. Day himself has publicly stated on the record that Canadians don't have a moral or a legal right to health care. He's said that many times in his presentations. So his Kempe Corp case is trying to enforce indirectly that which he has stated does not exist. The second flaw in the motion is that, as phrased, it implicitly invokes a perfect, albeit imaginary and non-existent system against which it judges ours to be broken. There is no perfect system in the world, in the Western world, not of Britain, not of Netherlands, not of Germany, and no, not even of France, that Dr. Day quotes all the time. Thirdly, there's no bar in British Columbia to private practice and private pay patients. All you have to do as a doctor is unenroll from MSP, go and treat people at your clinic, charge them whatever the market might bear. What in fact Dr. Day is trying to do with the case that he's brought before the courts is to actually upend the entire system. He's asking for 3 things. 1, he's asking for private insurance in addition to the MSP, Medical Services Plan of British Columbia, which is private queue jumping insurance essentially. Number 2, he's asking for the ban to be lifted from dual practice. If you're in public practice, you can't privately practice. Look what happened in England. They're allowed to practice in public and in private. And a couple of weeks ago, the Guardian was filled, the front page was filled with shutdown of the emergency clinics and need for the doctors, and they were paying them awesome fees just to get them in to do the shifts to look after them. So nothing stands in the way of Dr. Day actually getting out of the system, setting up his clinic, and treating both rich and poor alike. But I know that the poor who might suffer on the waiting list, there's no question, our system isn't perfect. You know, we have a system that is single payer, universal, accessible. Perhaps sometimes it's not accessible to everyone at the same time when it's needed. But the fact is that the system came from where, in fact, people used to go bankrupt. They'd have to make a choice between food and medicine. They'd have to make a choice between filling a gas tank, as one woman just said in British Columbia, or buying prescriptions. So we have come from there. Therefore, our system has evolved to meet our needs. Now, fourthly, in any event, I believe, as one of the deans of law that debated with Dr. Day said, this matter doesn't belong in the courts. It actually belongs in the political arena. It actually belongs in the debate halls. We need to improve the system that we have. Now, the court may decide that, like in Chowley, court didn't decide that the Canadian Charter of Rights applies to healthcare or Section 7 applies to healthcare. The court decided that to certain procedures, the government was negligent in terms of not providing quick care, and the government of Quebec basically legislated limits on waiting on those three areas, opened up those three procedures to private practice, to private insurance, and there are no takers, even in Quebec, of private insurance in Quebec that's now available. And in any event, what Dr. Day is trying to ask the court is not a writ of mandamus, not an order from the court that all governments in British Columbia, the governments in British Columbia and all the provinces and across the country, because Canada has a big responsibility for the Aboriginal care at least, that all governments provide care in a reasonable time without having people to wait for long times. No, he's not asking that. That's not gonna, what he's asking isn't going to help an ordinary Joe in a queue, in a lineup. He's asking for the whole system to be opened up. So, the court might find, the court might find that there are limits to those rights. And in a free and democratic society under Section 1, some of those rights, some of those limits to those rights might be justifiable. Now, that's not to say that what we have in Canada is acceptable in terms of wait times. I know that in many areas, in fact, when I was the Minister of Health, we pumped $42 billion into healthcare over 10 years because we knew that we needed to deal with these issues around wait times on cataracts, knee and hip replacement and things of that nature. And in a couple of years, in a year and a half that I was the minister, in fact, in many of the provinces, some of those wait times came down, and in fact, the waits had been reduced. So much so that in the middle of an election in 2006, the provincial ministers were insistent that I show up at their announcement as to how they had reduced wait times, although I was a candidate in that election. And because we cooperated with each other, worked with each other to make those reductions. Now, as I have said, we have a system that is not perfect. As I said, Dr. Day is asking for those three things, and those three things would create a problem. He says that if you have private insurance, that somehow solves the problem. It doesn't. You look at Europe, and we don't live in Europe. We live right next to the US, and I'll come to that in a minute. In Europe, in France, you have private co-payment insurance. Every individual is forced to make a co-payment in addition to what the government pays for procedures and the like, and you have to buy that private co-payment insurance. And they still have problems. In Germany, they allow people with a certain amount of wealth to get out of the public system and go into the private system, and in fact, they are rarely allowed back, and they're having problems. They're now thinking of realigning the entire system to make sure that they have some equity in the system. In England, physicians are employees of the NHS. They work 40 hours in public and then they go work in private. How many doctors would like this in Canada? I'd like to know. I'd like to know whether Dr. Day, in fact, would like that system where he's forced to work 40 hours in the public system, then he can work the rest of the time in the private system. And you still have long waits and inequitable access in places like England and other places. And in Australia, in fact, you have a subsidy of $6.8 billion this year to people to buy private insurance in addition to the public insurance they already have. And their system in the last 20 or so years that this subsidy has been increasing and ongoing, the public system has deteriorated. And it's not as good as it was. It's not any better because of the so-called competition that Dr. Day and others talk about. And then, as I said, we live next to the U.S., the elephant. And we know the experience in the U.S. Trump is now trying to undo Obamacare. I understand that they're one vote short in the Congress today, and they might, in fact, pass that legislation. But we have something called NAFTA. NAFTA isn't going anywhere no matter what Trump says. We have NAFTA. If the courts open us up to private insurance, what would happen would be a floodgates of private insurance companies coming from the U.S., and if they can't control their insurance companies, and we know they can't, we wouldn't be able to. We are a much smaller economy than they are. They're a much bigger economy, and I'm sure that many of them would like the opportunity to come and financialize our health care as they say it. Now, Dr. Day and others argue sometimes that our costs of administration are very high. You know, Canada Medicare spends 2% on billings. U.S. public health care spends 3.1% on billings. Private is through the roof, like 18 to 30%. And in fact, you have hospital admin costs. I've heard Dr. Day argue about those. Recently, the recent study in 2014, it says multi-payer systems pay more. U.S. pays 25% of their total Medicare costs, hospital costs. Netherlands 20%. England 16%, and single payers pay less. Canada and Scotland, only 12%. We hospitals pay only 12% of the money they get on admin. Now, can we rest on our laurels? No, we can't. The politicians in this country need to do more. And the doctors and the nurses and others who are at the front lines of the healthcare, they need to cooperate and find imaginative solutions. And there are many. You know, there are BC Pathways, and you have Ontario's email consult initiative, you have Newfoundland Province's referral program. You have many of those initiatives that are trying to do what Dr. Day is legitimately complaining about, long wait times, mainly for elective surgery. Emergent care and urgent care is easily and generally speaking very well looked after across the country. Knee, hip replacements, cataracts and the like, obviously people suffer, and that is not acceptable. And it is important that politicians work hard, and people ask the politicians to work hard. And as I said, law is not the solution for this. Ultimately, it is our collective effort that is the solution. I know Dr. Day, I've watched his many presentations, and he talks about anecdotes, and I'll deal with some of those in the rebuttal. But you know, anecdotes make compelling case. They tug at your heartstrings. They pull at your heartstrings. They make you weep. But if you contextualize them, they're painful. If it happened to my family or your family, we'll be screaming blue murder. Absolutely, I understand that. But anecdotes, as you say, as in law, bad cases make bad law, or hard cases make bad law. It's the same in healthcare. Anecdotes make bad healthcare. Let me give you an anecdote. I have a friend who's 85 years old. He's lived in Canada since 1965. And I came to Canada in 68. He is from India. And he's gone through heart attacks, knee replacements, hip surgeries, and he's been in and out of the hospital, and he's now homebound with some home care. And every time I talk to him, and I talk to him about once a month because he calls me just to say hi, he says, Canada, I know it has problems. Everybody cries about them legitimately, but Canada's heaven. If I wasn't in Canada, if we didn't have the kind of health care we had, I wouldn't be living today. Should I take that one anecdote or a million others like that in Canada and say that there's nothing wrong? No. Obviously, we need to make sure that we deal with the wait times and we deal with them properly. Now, as my friend Romano said in his commission report, you know, Medicare is a moral enterprise, not a business venture. And I say it must always remain a public good, never become a commodity. And what Dr. Day is promoting will make healthcare a commodity, out of the reach of many Canadians, particularly people who are in the lower socioeconomic strata. Privatization is not the answer. I've gone through some of the countries that have mixed systems. And Dr. Day says, well, we have private care. Yes, we have. 70% of the healthcare money is in the public domain. We don't control delivery. Canada Health Act, that's the devil, according to those who want to break up the system, doesn't say anything about delivery. It only talks about the 5 principles and public pay, single-payer system. There is 30%, it doesn't say you should have private. Most of our delivery is non-profit institutions, non-profit charitable institutions, hospitals and the like. 98% of delivery is private by non-profit hospitals and the like. And Dr. Day talks about us having a government monopoly. We have what is called a monospony. We pay. It is a single-payer system. It's not a monopoly over care. The care is provided by private, non-profit hospitals. So it's totally wrong to say that government somehow prevents the doctors from doing that. I urge Dr. Day, if he's a supporter of privatization, he should get out of the system, set up a clinic, invite people from all over the country to go to his clinic, and let the market bear. I believe that if the court allows him the opportunity to do what he wants to do, we won't have the system we have. I'm sure the Charter of Rights doesn't give you a right in health commerce. It may gives you a right to health care. It may not give you a right to commerce in health care. Thank you.
Thank you very much. Dr. Day, the floor is now yours for your 5-minute rebuttal. We look forward to your remarks, sir.
Well, yeah. Well, on the question of anecdotes, 85,000 anecdotes waiting on hospital waitlists in British Columbia. On the question of the private insurance in Quebec, the Quebec government did not obey the Supreme Court of Canada's ruling is basically what happened. They introduced, they legalized health insurance for cataracts and joint replacements. Now, who in this room would go and buy a policy to insure yourself against cataracts and a hip replacement and nothing else? The problem is that Ujjal is failing to understand the fact that this is a human rights issue. This is a situation in which children, as I said, 2/3 of the children at BC Children's Hospital are waiting for health care and deteriorating as they wait. It's not an anecdote when there are thousands of them, which are listed on the BC government website. And if you extrapolate the 85,000 across the country, that's about 850,000 anecdotes waiting for health care. And to me, that's unacceptable. You know, after the Charlie decision in 2005, Patrick Monahan, who was the dean of Osgoode Hall Law School, wrote that where publicly funded systems fail to deliver timely access, governments act unlawfully in prohibiting Canadians to use their own resources to access those services privately. Our case in BC is about forcing governments to obey the law. It's as simple as that. We started our clinic over 20 years ago under the regime of Ujjal Dosanjh, endorsed by the politicians in his caucus. We targeted injured workers. They are exempt from the rules. Our clinic, and clinics like ours that came afterwards, saved the Workers' Compensation Board $200 million a year in wage loss benefits alone. That's why organized labor, that's why the NDP government that Ujjal was in, that's why they endorsed what we were doing and allowed us to open and carry on. We now still serve those groups that I mentioned, we don't have, I'll reiterate this, I said it earlier, we don't have a single payer system. One of the witnesses in our case is an individual who tore his knee ligaments in one knee, got an MRI within a few days, and surgery within a week because he was injured at work. A year or two later, he injured the other knee with an identical injury, would have been covered by a disability insurance if the law had allowed the disability insurance to pay for his surgery. Instead, because of the law, he was waiting for 18 months, being paid $5,000 a month by the disability insurance company who would have liked to get his surgery done just in the way the Workers' Compensation Board did. These exempted groups, they just blow a hole in this descriptive of a single payer system. There is no such thing in Canada. There is no such thing anywhere in the world. And to deny that countries like Denmark and Sweden and Holland and Belgium, all of which have hybrid systems, are not delivering good healthcare is ludicrous. In Germany, you do not wait for healthcare, despite what Ujjal says. The same in England. 18 weeks maximum from the time your GP sends you until your surgery or procedure is completed. And if that timeline isn't met by the hospital, you can go anywhere in Europe and be funded by the government privately. So a lot of this will come out as evidence at trial. It's difficult in a debate because it's he says, she says, but I can tell you what the points I've just raised are true. They will come out at court, and the evidence will be clear before the judge. Thank you.
Thank you. Very well, Mr. Dosanjh, the floor is yours for your 5-minute rebuttal on this.
Well, first of all, Chowley case, Dr. Day says that in Quebec the government is flouting the law, the court order. Obviously not, because the issue was with respect to 3 areas, cataracts, knee and hip replacement. The government legislated the reasonable wait time and allowed people to buy insurance if they still wanted to buy insurance if the government couldn't live up to those limits. And nobody's bought insurance. And Dr. Day talks about my time in British Columbia. I was Attorney General for about 4.5 years, and then I was the Premier for a year and a half. I think he's talking more about my time as Premier. Dr. Day, if you read the news clipping that the Institute has it on its website, but if you go behind and you read the whole interview with the Guardian, which was the healthcare paper at that time, I said I want to actually shut you down. I couldn't do it because we had wait times, unacceptable wait times, and we were putting more money into healthcare than ever before. And in the upcoming budget, if I had won the election, I had made the statement I was going to put more money and then shut you down. Because I genuinely believe what happens with the healthcare clinics, private healthcare clinics, is that 15 or 20 or 30 specialists or doctors that operate out of Dr. Day's clinic are lost to the public system. Nurses, anesthesiologists, and others are lost to the public system. And Dr. Day is lost to the public system. If they were in the public system and tried to make it better, we would be all better for it. But his whole issue, and this is nothing personal, he's a good man, I like him very much, but the whole thrust of Dr. Day's approach is not asking the court to order that each and every Canadian get reasonable, accessible health care, single payer. The whole thrust of his approach, his whole thrust, is to ask the court to open it up to private insurance, undo the ban on dual practice, and then undo the ban on extra billing. And the fact is that if you do that, it would just destroy the single payer system. There isn't a system that Dr. Day is talking about. Ask him about France, ask him about Germany, ask him about Netherlands, ask him about Sweden. There isn't a system that allows those 3 things plus single payer system On top of that, you can double charge, extra bill. You can work in both systems. There isn't a system like that. And my friends, we sit not next to Sweden. We sit next to the US. There are some imperatives because of that. Our competition is with the US. Our dream might be to follow Europe in some instances, but our reality is that we have to deal with the US, so we have to deal with NAFTA. We have to resist this case. Dr. Day talks about the evidence in the case. I haven't attended the case at all. Those who have followed the case or attend the case hearings regularly tell me that much of the evidence has been undermined and questioned. And that some of the anecdotes he talks about, there are other explanations for those anecdotes. I don't want to drag individual anecdotes in here. I believe that ultimately what you need on behalf of Canadians is a healthcare system where people don't have to wait for elective surgery or don't have to go through pain. But there is no system in the world where you simply turn the switch on and you will get treatment next instant. In Canada, emergencies, if you have a heart attack, you go to the front of the line. If you have an injured head, you go to the front of the line. If somebody's waiting for an injured arm, they get pushed behind a little bit. Those are accommodations we make. There is no absolutely perfect system in the world. Therefore, we shouldn't judge our system vis-a-vis an imaginary, non-existent, perfect system. Thank you.
Thank you very much. Well, now we can open the floor to questions. So if some of you have questions you would like to put to our debaters, we'd be pleased to hear from you. Perhaps the easy way is just raise your hand and we'll get a microphone to you, okay? There's one up there. We'll start with that. And there's a second and there's a third. Okay, so that's the first three. Sir.
Just, Mr. Dosanjh, I agree, no one has a perfect system, but the statistics comparing our system to other countries suggest that our system is really quite bad. My question relates to the issue of double pay or whatever it is, and I'm not quite sure how the system really works. Whether or not, I do understand that the provinces set fees for service, and I guess my question is the issue that if someone like Dr. Day wants to charge for a service, that he either gets it directly from the patient and nothing from the government, or is it that if the government pays, then he's not allowed to collect from anybody else? And I must say my own preference would be, if there's a long wait time, that if the doctor wants to charge more than the government pays, I'd like the government to pay because my taxes go to do that. But on top of that, I would like to be able to pay out of my own pocket if it will somehow get me a service that I really need.
Thank you. The second question will be up there. Mm-hmm.
Yes, we do live close to the U.S., and I think we need a fact checker. Some of those statements made were just ludicrous in terms of the government has no control over how the hospital up here, has no control. The government provides the money, which is grossly underfunded. You just have to visit an emergency room these days and see the disaster that's going on in the emergency room. It's underfunded, understaffed. We need a fact checker. You said that the administrative costs at the hospital are very low. They're huge. 70% of the hospital costs go to administration. We need some fact check, and I would like to see your talk that you gave and do a snoops.com on it.
Thank you. And our third question is here.
Okay, so thank you to you both for being here this evening. Really appreciate it. Mr. Dosanjh, my question's for you, though. I'm wondering if you can speak a bit to the mechanics of the breakdown of the system under a system as you believe your proponent or opponent would propose.
Okay, so Dr. Day, we'll start with you. You have 3 minutes to respond to the three questions.
Okay, on the first one, the administration costs are grossly misrepresented by the self-reporting of public hospitals in Canada. Barry Turchin presented at the Canadian Medical Association some years ago, and what he did is he went for freedom of information and compared the administration costs in BC hospitals with under Medicare with the similar costs in US Medicare. So he was comparing like with like, and the Medicare costs in BC were exactly double. And he found what was happening is that the public hospitals were calling a vice president of medicine a doctor and clinical, even though he they were not counting that person in the administrative staff because he had a medical degree, and similarly if they had a nursing degree. Secondly, just on the doctors leaving the public system and not working in it. We have in my specialty of orthopedics, the biggest wait lists are in my field. We have 178 young orthopedic surgeons in Canada who cannot get a job. The public hospital won't let them work, even though people are waiting a year or two for surgery. And finally, just to respond to the why doesn't everyone just go and do private practice? By the way, Ujjal was completely wrong on the Quebec issue. They did not obey the laws as dictated by the Supreme Court of Canada. It was private insurance, period, not for cataracts and hip replacements and so on. And finally, 76% of doctors, more than 76% of doctors, do not want to be on fee-for-service. So yes, I would take the 40-hour week in Britain and the pension plans and everything else that goes with it, and the holiday pays and and all of those benefits. And most doctors in Canada want out of pure fee-for-service, and a lot of individuals don't really realize that. The point we have to make is that when we started our clinic, we doctors had our operating times cut back from 22 hours a week to 5 hours a week, which is almost 10 hours less than the Canadian Orthopaedic Association says is necessary for maintenance of competence. So to suggest we leave the system is completely wrong. We are not being allowed to work in the system, and that's because of rationing of funding and access to care in Canada.
Thank you. Okay. Mr. Dosanjh, the floor is yours for your 3-minute response.
Well, first of all, it's not the patients who put themselves on wait lists. It's actually the specialists most of the time that put people on the wait lists. Now, there is an anecdote that I can tell you from British Columbia. There was a specialist who was booked and told the patient that it would take over a year for the patient to see him, except if he came to see him in his private office, and the patient went, paid $500 extra. Then it was moved up on the public list and was actually treated in the public domain. The gentleman was asking about what's the extra billing. Extra billing is what Dr. Day wants is the ability to charge the government for the prescribed fee in addition to extra bill.
That's false.
Well, you want the extra billing unbanned.
No.
Why would you want the extra billing unbanned?
We're not. That's not what we want. We don't want.
Well, Dr. Day, if you don't want that, you're free to go out of the system and charge what you like.
No, the patient is not free to buy insurance. Therefore, only rich people can go out of the system because your government and governments that have followed won't let private insurance be legal.
Dr.
The only country on earth where it's illegal to buy
private insurance. I know you're taking my time, but insofar as the law is concerned...
Well, you asked me a question.
Yes.
Insofar as the law is concerned, you are free to walk out of the system, go treat whoever you like, for whatever money they pay you. For cataracts, for knee replacements, for hip replacements, you're free to do all of that. I don't see why it is that you have to actually undermine the entire system. In terms of, that's the issue. Being close to the U.S., yes. you know, we have difficulty with we had problems with the emergency care, but so does England, that has the two-tier system. They have problems. They have huge problems. Read The Guardian from a couple of days ago. You asked me a question about the breakdown of this, how if you allow a two-tier private system to be developed, it sucks the personnel, the doctors and the nurses and the others into the private system where they might get paid more. The sky is the limit. Rich people are prepared to pay. And the rest of the system suffers, has longer wait times, the hospitals suffer, and the care suffers. That's how it disrupts the system.
Okay, 3 more questions, if there are those who'd like to ask. We'll start here. 1, 2, okay, and 3. Yes, right here we'll start.
Right here?
Yep.
I've got two
Oh, all
questions.
right.
I've got 2
He's
questions for Dr. Day. They'll be very fast, and they are: you've been thrown a challenge by Mr. Dosanjh of why don't you go out and work in the system? And so my question to you is, are you prepared to go out and just work and not be subsidized by the government, and then just take your clients from where you get them and the money that they have, and so you wouldn't have access to my taxpayers' dollars? And the second one is, I think I just heard you say that you'd be prepared to have a 40-hour week and you'd really like that. So my question is, why aren't you using your considerable resources to advocate for better health care and for better situations for doctors within a publicly delivered and administered system rather than the court cases that you're taking now?
Well,
Nope. 3 questions first. Sir?
Okay, I just wanted to address what seems to be sort of a very licentious use of anecdotes. One, it seems like Dr. Day is, and this is, I guess, to you, there are some anecdotes that are complete stories, and there are some anecdotes that just don't really make any sense. The anecdotes that are complete stories, I mean, we've all heard of the bad stories, and that's very concerning, and I think that everyone acknowledges that there can be improvements that are made. But for every anecdote that exists that tells a bad story, there's probably any number of anecdotes that would suggest a really good story. I mean, I can think of off the top of my head, people getting diagnosed with cancer within 2 weeks, seeing the best cancer surgeon in Princess Margaret Hospital, and having continuing care throughout radiation and chemo for 2.5 years and not paying a cent. I know people who've had a certain threshold of symptoms that have then gone to their doctor and have been diagnosed with MS within 2 weeks, seen an amazing specialist and not paid a cent.
Okay.
But I think that there's one really quick point. The point about the Children's Hospital in BC, you mentioned that there's some disaster going on there. I don't think anybody in BC would acknowledge that there's a disaster going on at Children's Hospital.
Time is up. Okay. 3rd question, sir.
This is a very emotive and complex subject, and I'm very grateful to both speakers for their contribution. However, I do have a problem, and that is the wording of the resolution. As I understand the resolution, it says our broken healthcare system is infringing on the rights of Canadians. And I have not heard either speaker address what perhaps is a legal issue of what are those rights that might be being infringed. Thank you.
Okay. Sir, Dr. Day, the floor is yours for your response to these 3 questions.
Well, our clinic doesn't bill the government or the medical system for any fees whatsoever. So we are completely free of public funding. And our lawsuit is asking for the legalization of private health insurance completely outside of the public system. So this would be nothing to do with the public system. There'd be no public subsidy. We're basically saying, you can go and buy health insurance for your pets. On what legal grounds should you not be able to do so for your loved ones? And that's the question. With respect to the anecdotes, of course, if 20% of people are not being treated in an appropriate time, well, then 80% of being treated are being treated in an appropriate time. So there will be more. I mean, no one is suggesting that the Canadian health system is failed to that degree, but there should, in a rich country like Canada, we should not be experiencing patients suffering on wait lists. And the issue about the Children's Hospital, the chief, Jeffrey Blair, was the chief of the Pediatric Surgeons of Canada, did a study in which they concluded that 2/3 of the patients waiting at BC Children's Hospital were waiting a medically unacceptable period of time as judged by the doctors. So that's a study out there, and it's in the Canadian Medical Association journal. I don't remember any of the other questions.
Sir, Mr. Dosanjh, the floor is yours.
I'll address the legal issue. I believe I did address the legal issue maybe somewhat quickly. I believe, as I said, the motion is flawed on several counts. What Dr. Day is seeking is a legal right to commerce in health. It's legal right to buy private insurance. It may be for health, but he's not asking for a legal right to health care for all Canadians up to a certain standard. That's the nub of the legal question. And the court, you know, I just used to be an attorney general. I was a lawyer. I wasn't a constitutional lawyer. So I can't tell you what the court might do. The court might actually reach that conclusion pursuant to Section 1. If I believe in the Charter, there's a limitation saying these rights, including the Section 7 rights that Dr. Day is using, that these rights are subject to reasonable limits in a free and democratic society, limits that may be demonstrably justified. And I believe the court might come to the conclusion that this is such a complex issue, the court must not pronounce on it. The court might say that these issues belong properly in the political domain and not in the legal domain, and whatever appropriate reasonable limits, so they may say whether or not the limits imposed by the law, both in the provinces and federally under the Canada Health Act, whether or not those limits are reasonable and are demonstrably justified. The court might say or answer in the affirmative to that particular question. I hope it does. That's the legal issue.
Okay. 3 more questions from the audience. Are there others that would like to put one? Okay, there's 1, 2, 3. Oh. Okay. I don't know how they saw you. I didn't. Okay. Sorry, but go ahead.
Okay.
All right.
I had the experience of moving here from Vancouver 3 years ago. I had pretty good experience with healthcare there, and came here with my family. And I have to say, we had very unsatisfactory service here, just trying to get a GP in the first instance. But then, you know, once we sort of got through that process, found that it really seemed like nobody in the system cared, you know, and I feel really in you know, as part of a commodity. I mean, the doctors swipe my OHIP card to get $30 every time I come in, which means I get about a 6-minute focus of their attention. If I've got 2 problems, I can't talk to them about it. I've got to make another appointment, and sometimes I have to wait 30 days just to make an appointment to come in and see a doctor. And it just seems to me this system is terrible. And if there was what I feel just some sort of competition in the system, it might urge people to care a little bit more, try a little bit harder. I just can't help but feel that the experience reminds me of the time I went to the Soviet Union a long time ago, where people would wait 3 hours in line for a loaf of bread and nobody cared because that's the way it was. Okay. And don't you think some competition might just improve the way that healthcare is delivered?
Okay. Second question. Where's the microphone?
The first point is I fail to see how the private care will reduce the waiting time for those that can afford it significantly. Second point is these issues have been going on for a long time. yet Canada stands in the high 20s in rating. What's this country not doing not to be in the first top 5, for example? And the last point is it legal, or isn't it legal or allowed for those seeking treatment outside the country to get paid for it, especially if the wait time cannot be met?
Okay. What those outside the country should get if they get something done outside the country because the wait times are so unacceptable in Canada, basically, is the question. Okay.
Yeah. In the last year, I've had to use the healthcare system twice, and I actually live in Vancouver, and I have to say I've been extremely pleased with both events. On March the 1st, I had to call 911 to take my husband to emergency, VGH, and within an hour, he was admitted. So, and it was neurovirus, so it wasn't a heart attack or anything, but it was excellent service. The other thing was cataracts, and I'm a little confused with the fact that you don't have the option to go private with cataract, because it did take 2 months to get to see the specialist. And then when we did, he told us it would be a 3-month wait, okay, for surgery. And if I wanted to go private, he did both. So it would, he was going to do either, okay, just in a different facility. But it would cost me $1,500 more to go private with him, the same surgeon. So I asked him, well, what do I get for my $1,500? And basically he told me nothing, because the wait times were the same in both the public and the private. So I'm a little confused here, okay, about, because cataracts always come up as one of the wait time issues.
Okay, thank you. Okay. Now there's one more question. Maybe we'll allow a fourth one in this case because of the Miss County here. I'll allow one more.
Thank you. I'd like Mr. Dosanjh to comment a little bit. There was a couple references to NAFTA and the fear of the U.S. insurance companies coming into Canada. My comment, I guess, is with regards to competition. Canada does so well in financial services. Why is that such a concern that we couldn't compete against those United States insurance companies? It sounds like that is more a cause of concern than the potential double dipping.
Okay, thank you. We'll turn to Dr. Day then for the first 3-minute response.
Well, on the out-of-country question, governments in Canada are supposed, under the Canada Health Act, to cover you, first of all, when you're out of the country. As many of you who've been out of the country might know, if you do need care out of the country, they only pay $75 a day, say, for a hospital, which is nowhere near what it would cost you. In terms of the cataract question, that doesn't make sense to me either. So I don't know why someone would pay if they didn't have to pay, and I don't know why he would offer you the option of paying if you didn't have to pay. So, but there's lots of evidence that we're not performing well. Now, I'll just give you one quick anecdote on out of country. We were told, if you look at countries other than Canada where there's a mixed public and private system, the waits in the private system can be double that in the public system. So I went and looked up one of the waits that was referenced, and it was for an MRI. And the wait for an MRI in Canada, depending on where you live, can be up to a year or longer. In this particular country in Europe, the waits, it is true that if you were had private insurance, this is a country with universal healthcare and no waits, like Germany and Switzerland. If you had private insurance, you waited 3 days for an MRI. The terrible thing was that if you were in the public system, you waited double that length of time. You had to wait 6 days. And so the evidence is, which someone alluded to earlier, that when you introduce an element of competition, the public system has something to be measured alongside, which we lack in Canada. I don't know a single monopoly in any area, private or public, that is good for the consumer. And that's what we've got. When it comes to physician and hospital services in Canada, the government has a monopoly.
Mr. Dosanjh, the floor is yours, sir.
The government, in fact, doesn't have a monopoly because, Dr. Day, you are a private practitioner, whether you're in public or in private. All of the doctors are private practitioners. They pay their own bills, pay their own rent, pay their own employees. They charge the government. The monopoly is on the responsibility to pay so that ordinary people don't have to pay, get their credit card out when they go to the doctor or the hospital. That's where the monopoly of responsibility. It is not the monopoly over business. It's the monopoly of the responsibility to ensure that that happens. Now you asked about competition. In Australia, they in fact created artificially the competition by allowing private insurance and mandating it. So they spend about $6.8 billion in subsidizing private insurance for Medicare in Australia. And it's no better. The public system is no better today. That's why Dr. Day isn't talking about Australia very much.
My brother lives in Australia. Another false statement.
You're taking my time again, Dr. Day. Just in terms of talking about $6.8 billion, Dr. Day talked about how we had private health care in Canada. We do. 30% of our health care, our extended benefits and the like, are private. But they shouldn't be. We should be an aspirational country. We should be expanding health care, to have a national pharmacare program, to put home care into the basket of services, to ensure that we expand care, we improve the lives of Canadians, and end the wait times as well. In terms of why I raised the issue of national pharmacare, the private industry made, in 2011, $6.8 billion more in the private health insurance in Canada than they paid out. So Canadians paid to the private insurance companies $6.8 billion to get the benefits they need, more than they needed to pay. Those $6.8 billion in 2011 would have funded half the national pharmacare program in Canada at that time. That would benefit millions of Canadians. And we need to do that. We need to be more aspirational. We don't need to undermine the system. It has flaws. We need to improve it. But we need to reinvest more money, more resources, and expand it rather than shrinking it. Thank you.
Well, thank you for the questions. So we're now at the concluding remarks from each of our debaters. Dr. Day, the floor is yours, sir, for a 5-minute concluding speech.
I would ask Ujjal why he didn't, when he was the Premier and then later Minister of Health, implement what he now says would be a good idea. Probably it wasn't a good idea then when you were in charge. The fact is that that I, when I was CMA president, called for universal pharmacare, physiotherapy, extended health benefits for everybody, but not in the manner and style of Medicare as it is now. I don't think Canadians would want to wait 6 months or a year to get in to see a dentist or line up outside a pharmacy for waiting for months for their prescriptions. But one of the things we have to go back to is our system. The international ranking is poor. The Commonwealth Fund ranking system is referenced widely by the Canadian Institute for Health Information, a federal body, and by Canadian health ministers. 10th out of 11th is unacceptable. There's a hockey game on tonight. If we were the 10th ranked hockey team in the conference with 11 teams, would we be pointing at the 12th system and saying, oh, look at that terrible US system? No, we'd be looking at the top 2 or 3 teams to see what we could learn from them and what we could do. So does anyone really buy the argument that it's our system or a US system when there are at least 195 other countries on this earth? We need a universal system that supports the needs of the poor and underprivileged. Stats Canada says those people are not being treated in our current system. They have the worst access and worst outcomes. Where Ujjal and I differ is that I don't believe in a monopoly. And however he tries to paint it, when it comes to hospitals and physicians, to call our public hospitals private hospitals is ludicrous. They're run, operated, and funded and controlled by the government. It isn't a coincidence that countries like Denmark and Sweden and Belgium and Holland and Switzerland and Germany all outperform Canada in virtually every way. They have prescription drug coverage. They have coverage for mental health. We don't. If Canada has such a great system, how can it be that not a single one of the other 196 or so countries has ever copied it? When I was CMA president, I wrote to auditors general across the country, asking them to review the system. I thought, let's have an objective review, and especially the wait list and the unfunded liability of wait lists. We did a study that showed that Canadians were suffering economically as well as medically while on wait lists. Sheila Fraser, the Auditor General of Canada, had previously looked at Health Canada and said her conclusions were, we expected Health Canada to set priorities on the basis of good evidence-based information. No such luck. It did not subject high-value projects to rigorous selection. Weaknesses were broadly applicable to the branch's entire $350 million budget. This is the government. So a vote against the motion today is a vote in support of a system that's harming Canadians. The motion that our broken health system is infringing on the rights of Canadians applies not just to legal rights, but also to the ethical and moral duty that we have to look after the sick and injured. We can do better than 10th out of 11th. We can do better than 30th out of 30 in value for money. I met with the provincial health minister last week. He confided that he wanted us to win our legal challenge and believed that every health minister in Canada wants us to win that challenge because they don't have the guts to do what they should be doing, just like governments in the past haven't. The question is, should a Canadian living outside of Quebec who's suffering on a wait list have the same protection under the Charter that the Supreme Court of Canada granted to residents of Quebec? You must answer that question today. The fact is that we are not serving Canadians with our system. Patients are, in the words of the Supreme Court of Canada, this is the same court that legalized abortion, same-sex marriage, homosexuality, gave prisoners the vote, safe injection sites, and assisted suicide. This is not a right-wing court. It said Canadians are suffering and dying on wait lists. That's not me. That's the Supreme Court of Canada. They are not a prejudiced right-wing group, as far as I know. So if you don't support the resolution today, you are saying Canadians shouldn't have the rights to look after their own bodies. You're saying that your body belongs to the government, not to me.
Thank you, Dr. Day. Dr. Dosanjh, Mr. Dosanjh, I'm sorry. The floor is yours, sir, and we look forward to your concluding remarks.
Maybe I'll ask Dr. Day afterwards which political party did that minister belong to. But
same as you.
Well, I would say I'd like to see it.
I'm going to answer
You're
it.
taking my time again.
Well, stop asking me questions.
I didn't. I said I'll ask you afterwards.
Yeah, but I wouldn't remember the question.
Now, Dr. Day is saying if we don't have right to our bodies, who does? The motion doesn't talk about our bodies. Dr. Day's challenge in the court doesn't talk about our bodies. It doesn't talk about your right or my right to health care as Canadian citizens. It talks about right to private health insurance. That's a very different question from violation of legal rights. I don't know whether Canadians have a right under the Charter to private health care. That's the nub of the issue that Dr. Day actually presents to the court. I would say that if you vote for the motion, you are voting to ensure that we open up healthcare to private commerce. It isn't about equitable, universally accessible, single-payer funded, first dollar coverage for all Canadians without discrimination. It is about the motion. If you vote for the motion, it is about saying we should open up to private health insurance. We should unban the extra billing on top of the government fees that doctors have, and that we should allow them to both practice in public and in private at the same time so they can just gouge people. Now, I come from India. I grew up in India. I was 18 when I came to Canada to England in 64 and Canada in 1968. My mother died of tetanus when she was in her 20s, and I was a kid. I have experienced that healthcare system. I've also experienced the healthcare system here, from a spinal fusion in 1970 to a heart attack in 2007, and many other things in between. This system, and I wasn't always an elected politician. I wasn't always a reasonably known guy, and I wasn't always a lawyer, and I wasn't ever rich or influential otherwise. But that system, this system that we have, never looked to my wallet, never looked to my credit card, never asked for private insurance, never asked for co-payment, never asked for user fees. That's the system that we're fighting for. If you vote yes for the motion, then you're voting to do away with the system. If you vote no to the motion, you are then saying we need to improve our system, but we don't want private health insurance. We don't want extra billing. We don't want doctors to be able to practice both privately and publicly. Thank you very much.
Okay. Well then, I put the question before you again to see what your views are. Our broken healthcare system is infringing the rights of Canadians. All those who support this proposition say it's correct. Okay. All those who say it's incorrect and are opposed to it. It's a bigger crowd than before. And any are unsure still. That's a smaller group. So the debate has been an interesting and lively one and quite persuasive. So I want to congratulate both our debaters on their presentations. And thank the Macdonald-Laurier Institute for organizing these wonderful evenings, this opportunity to have vigorous discussion on public policy, and a chance for you to come and hear people who are very knowledgeable in the field present their views. So thank you very much. And David, you're back. Okay.
Well, thank you, Peter. That was just a fascinating discussion, I thought. So thanks once again to our two debaters, Dr. Brian Day and the Honourable Ujjal Dosanjh, and our moderator, Peter Milliken, the Honourable Peter Milliken. Just a few thanks, and then we'll be on our way. Thank you to the War Museum for this terrific venue and for all the support we get from them, including the simultaneous translation that has been available tonight, so you don't have to listen to me try to speak French. Thanks also to the Heck Foundation for supporting the entire series, the MLI staff, Juanita, Mark, Allison, and Sean Ashuv, to our volunteers, Jared, Daniel, Yashika, and Danielle. I hope we'll all see you on June 6th. That's when our next debate is. We're having Andrew Coyne debate John Hondrick on the resolution, the government must act to save journalism in Canada, which should be an interesting evening, I think. Thank you all for your time again. Have a good evening. Oh, but thank you, Wendy. All right. Well, if you haven't taken advantage of the VME exhibit that is available to all ticket holders for the debate tonight, please do so afterwards. I think it's open for a little while, till 9:30. Thanks, Wendy. All right. Good night.